Hi, I'm Tari Turner, Director of the National COVID-19 Clinical Evidence Taskforce and an Associate Professor at Cochrane, Australia in the School of Public Health at Monash University. Welcome to Taskforce TV. I'm recording this today on the land of the Bunurong people, and I pay my respects to their elders, past, present and emerging, and acknowledge their ongoing connection to this unceded country. In this episode, we take a look at the care of children and adolescents with COVID-19 and focusing specifically on drug treatments for those groups. I'm very pleased to be joined by the co-chairs of the Taskforce Paediatric and Adolescent Care Panel, Asha Bowen and Brendan McMullan. Asha is a paediatric infectious diseases physician based at Perth Children's Hospital. She's head of skin health and program head of vaccines and infectious diseases at Telethon Kids Institute in Perth. She's an associate professor of medicine at the University of Western Australia. Brendan McMullan is a paediatric infectious diseases physician and microbiologist at Sydney Children's Hospital in Randwick. Brendan is a senior research fellow in the discipline of paediatrics in the School of Public Health and Community Medicine at UNSW. Thank you both for joining me today. So 2 years into a pandemic, fair bits happened in the last little while. I'm interested in your thoughts on what the key messages are right now for clinicians who are caring for children and adolescents with COVID-19. Asha, what do you think the key messages are?
I think that's a great question. I'm coming here from Wajak Budja, the lands of the Noongar Nation, working at Perth Children's Hospital. And as most people will be aware, Western Australia was pretty late to catch up in looking after children and adolescents with COVID-19. And we really only had that experience here in this state for the last few months. And so I think having the living evidence guidelines has been incredibly helpful in navigating our new experience with this disease, as well as being able to reach to clinicians across the country to understand better what's happening. What's the biggest priority right now? Well, the vast majority of children have a really mild illness. And so reassurance and continuously to stay as confident and as reassuring for most of those families who have children who have a relatively mild experience of COVID. And whilst a high fever is frightening for an individual parent, we as paediatricians see that as part of that mild experience. And so continuously reassuring how to navigate looking after children with COVID, making sure they're drinking well, making sure that they're getting paracetamol or other things that can help manage symptoms, and making sure that they don't need hospital level care. For the clinicians out there, it's really, really important that they know how to reassure those families, because that's the vast majority of the work, but at the same time have access to the living evidence guidelines so they can find out in the really tricky cases that are few and far between and really rare occurrences, well, what is the best evidence right now? How do I make sure that I provide the best level of care to this particular child right in front of me who is not fitting that vast majority of kids who have a mild illness? They are the ones that the guidelines have been written for, and they're tricky. They need navigating all of the information. And to be honest, as a clinician right now in that zone, I have been using the living evidence guidelines myself all the time, re-looking at the evidence, re-looking at the numbers, re-looking at how much do I understand this from a child's perspective, and how much can I apply the evidence that's been generated in adult populations across the globe to the individual right here, right now in front of me. So I think that there's lots on the minds of paediatricians and clinicians at the moment, and those are some of my thoughts.
Brendan, I'm interested, you've had a slightly different track through the COVID pandemic than Asha. Similar thoughts, different thoughts?
No, absolutely. And I'm coming to you here from the lands of the Gadigal and Bidjigal people of the Eora Nation, and I extend my respects as well. Yes, it's amazing how far we've come in less than 2.5 years. And even though we've had a very different experience here in Sydney and New South Wales from the experience in Perth, there are a lot of common factors, and those are building on some of the things Asha has already said. So collaboration between clinicians, including using the Taskforce guidelines, and that's been a fantastic example of collaboration with really strong multidisciplinary approach. But also collaboration within our hospital systems and with parents and families. So we've worked together to gather really an impressive amount of evidence in a short time so that we know how to care for the majority of kids with mild illness at home, as Asha has said. And also, we've got great information now on the latest drug and non-drug therapies that we need to use for that small proportion of kids who are sick enough to come to hospital. So, and that encompasses the entirety of the COVID spectrum. So I guess the messages are, this has been tough, but we've been getting through this together, and we've really got some great things in place to keep building on that now and going forward.
I'm interested, Brendan, both you and Asha have flagged that there's been new treatments out in this last little while. I know that the focus has really changed from that acute hospital treatment to treatment in the primary care setting. And as you guys obviously are very well aware, most of the evidence is generated in adult populations. Brendan, are there specific things that people caring for children and adolescents and considering drug treatments need to be keeping in the back of their mind as they approach those kinds of decisions?
I'm glad you've thrown to me this time, Tari, because I feel like I get to say the cliche that children aren't little adults. It was going to be Asha or me, and I got to say it this time. But it's true that all of us who care for children, whatever type of healthcare provider you are, a paediatrician, someone in primary care, nursing, we know that we have to view paediatric treatment through a different lens. And people who care for children are really well trained to do that. We are used to interpreting data that's often generated in adult populations first, and then filtering that through our existing breadth of knowledge and collaborations and our partnership with kids and young people and their families to deliver targeted care for those. COVID has been in some ways similar in that most of the results came from adults first, but we do have excellent examples of studies that have been opened up to include children, like the recovery trial from which we're eagerly awaiting data. And of course, all the vaccine studies where we actually have specific data that has allowed us to deliver vaccination for COVID at age-appropriate doses and schedules. So, this is a trend of child health and adult health working together to deliver the best care for children and young people.
Yeah, obviously, Brendan, you're right. Lots of the challenges that paediatricians and others in this space are facing are the same as they would be facing for another condition or illness. Asha, are there some questions that are specific to COVID? As your colleagues perhaps locally are starting to deal more with children who might have more severe illness, are there questions that they're coming to you with, or that are burning issues for them?
One that's popped up, I guess, with Omicron particularly is treatment of croup. And that really wasn't part of the common experience of COVID early on. And to be honest, paediatricians are really good at treating croup, and the standard croup interventions have worked on the whole for most of this group. So we haven't really needed to construct a new evidence base for it, but it's just something to be mindful of, that COVID has changed in the way it presents in kids as well as the elderly at different time points, and being prepared for that, and then leaning on the ways in which we've already constructed treatment algorithms in order to adapt and cope with that. So I just think it's an interesting example because it didn't even raise its sort of appearance in discussion at the task force. We haven't really nationally had lots of conversations about, oh my goodness, how do you treat croup with COVID? Because we already knew how to treat croup. And fortunately, those regimens and management programs all work adequately for this. So a different viral trigger causing a similar clinical, phenotype in children, that has been, I guess, one of the interesting things. I do really think that we need more clinical trials specifically that do include kids. And as a clinical trialist, I really, really want to be involved in those. But it has been a good problem that we haven't got hard endpoints in kids that are occurring frequently enough to actually design trials around. Now, why do I call that good? Well, it's good because children are not dying of COVID on the whole, and the vast majority of children, as we said, have had a mild illness. And so we don't have enough information to decide whether a study drug is better or worse for a particular child based on some of the parameters that we would usually use in a clinical trial. I think it needs our innovation, and I do think it needs our collaboration to continue in, I guess, the years ahead to work out how we might actually test whether some of these regimens are adding benefit or doing harm in children specifically. And I do think that over the next year or two, we're going to have to relook at our thinking processes behind the way in which we have designed clinical trials and working out whether there are different ways that we might be able to work together. Because ultimately, the evidence that we have, we are able to extrapolate from it, but it would be so much better if we actually had a little bit more information about the safety, a little bit more information about the efficacy that was specific to the various age groups of children in the way that we have for COVID vaccines, as Brendan highlighted.
As you say, it's a good problem to have, but there may be other ways to look at it in the future. One area that was entirely new to me, and I'm still trying to get my head around, is what I've come to know as the acronym PIMS-TS. Brendan, what is PIMS-TS? And why are we interested in it as a clinical group?
Yeah, PIMS-TS or MIS-C, and I won't spell them out. Maybe we can put them in the comments below for people to look at. But they're an inflammatory disease that occurs usually in children less than 18 or 19 years following COVID. Generally around 2 to 6 weeks after COVID, although not always. And sometimes people don't know that they've had a COVID infection, of course, because it can be asymptomatic or undiagnosed. But it's essentially the defenses against infection being overstimulated and being overactive occurring after a COVID infection. And causing fever and sometimes rash, sometimes tummy pain, diarrhea, vomiting, a number of other features. But it can be serious and it can require children to go to hospital or even intensive care. Now, the good thing about it is it only occurs very rarely after COVID infections in children. And we've got much better at working out how to diagnose it and how to treat it. And we generally treat it with drugs that modify the body's immune response, so dampen down that overactive immune system. And those are sometimes drugs called corticosteroids and sometimes an antibody formulation called intravenous immunoglobulin. So I think we've been doing a lot of work to educate clinicians about it, and we've got good advice based on evidence in the Taskforce guidelines about that, but also provide information to parents. And so one of the messages around that to clinicians is make sure you consider if a kid is coming to hospital with prolonged fever and these other features, could they have PIMS-TS to get that diagnosis and treatment started early as possible. And the message to parents is it's really important when you're seeing a healthcare provider to let them know if they've had a COVID infection. So to prompt them to know that this diagnosis is on the cards.
It's reassuring to hear you say that it's rare, but it's also useful to make sure that message is out there that it's a thing we should be thinking about.
PIMS-TS has a lot of features in common with a disease that was already known to paediatricians called Kawasaki disease. And so I think building on the knowledge, a bit like the Croup story I said, has helped us very quickly work out what treatments might work, and also to have some knowledge blocks that paediatricians already have in place to be on the lookout for this. And some of the things that are, I guess, consistent between the two are prolonged fever, so high spiking temperatures that go on for 3, 4, or 5 days is something that's kind of quite classic. And so then there's some other features like red eyes or a rash that might appear that can be across both different ones. But then there are a few things that are remarkably different. So really helping paediatricians to learn from what they already know and then to be on the lookout. And something that is quite remarkably different is that Kawasaki disease usually affects kids from about 6 months to 5 years of age, whereas PIMS-TS, the most common age group is between 5 and really up to 12 or 13 years, but even out to the late adolescents, as Brendan has said. We found out already that for vaccines protect adolescents from PIMS-TS. And so that's been a really interesting part of the story. And we hope we might learn more about that for the primary school age kids. But it's been, I guess, that paediatricians observing the clinical way in which kids present, working collaboratively across the globe to try and describe these new features that have emerged, and then figuring out how to treat them. And then ultimately the task force job is to put that into guidelines that are accessible for everyone, so that if you're a paediatrician in Broome or you're a paediatrician in Melbourne, you have access to that same latest evidence and can use it for the patient who's right in front of you. Because although it's rare, with about 1 in maybe 3,000 COVID episodes leading to this presentation, we've seen over 100 cases across Australia in the last sort of 12 to 18 months. And so it is occurring, and you don't know where those children will seek healthcare. So it's really important that we have access to this information wherever the children do present.
I feel like I'm about to ask a question which is entirely flipping the kind of nature of the conversation, which is going for something very rare to something that's become incredibly common, which is pulse oximetry. So, 12 months ago, nobody had a pulse oximeter at home. Now it feels like everybody's got 3. What's the role of pulse oximetry for children at home with COVID? Asha?
So this is an interesting one as well. I think it's a really important monitoring device for adults, but I don't think it's all that useful for kids. And the reason for that is the ranges of normal are, I guess, very similar, but kids can be moving around and really difficult to get a good read on from a particular oxygen probe. We also know that the reason that saturation monitoring in COVID for adults has been important is because of the, I guess, inflammatory changes in the lungs that tend to occur sort of around that day 6 to day 10 post the initial COVID infection, that lead to them really struggling with their health, needing to go to hospital for oxygen therapy. Now, that process is extremely rare in children as well. So because of, I guess, that rarity, as well as the challenges in monitoring pulse oximetry in small children and even bigger, larger children, we haven't made recommendations to make this universal or routine, probably because we would see far more kids presenting to hospital with an abnormal result. And it wouldn't be the truth. It would just be that there was something, a bug in the actual way the monitoring was occurring that led to them needing to come to hospital. And so it would be over-seeking of medical care rather than providing that sort of sense of, oh, the sense check right now is I need to go for medical care. Brendan, what are your thoughts?
Yeah, I totally agree. I mean, I think the pulse oximetry in adults was a really interesting, and fruitful innovation during the pandemic. But as you say, it's got a very limited role in kids. So we can do home-based pulse oximetry for the very select group of kids who are going to benefit from this if we need to. And that already happens with some, premature infants who are going home from hospital for other reasons and things like that. So this can be done and it is possible, but as Asha says, it's almost never needed for COVID in kids. So we generally reserve the oximetry for that small number of kids who are sick enough to come to hospital, and we've got good facilities to do the oxygen monitoring then for those kids who need it.
Beautiful. We've already touched on the importance of research in a number of different areas for care of kids with COVID. Brendan, is there one or two really most important unknowns? What are the kind of hot topic questions right now?
Yeah, gosh, there are so many hot topic questions with COVID, aren't there? It's sort of hard to pick one. I mean, I think we are still really interested and concerned about the long-term effects of COVID in children and in adults who've had it at an individual and a population level. It looks like kids get persistent COVID symptoms pretty uncommonly compared to adults, which is a fantastic thing, but we need more time to study this. I'd love to have a crystal ball to know what was going to happen with COVID variants, and are kids going to continue to have mild disease as we hope? Will this turn into another seasonal coronavirus like the 4 or 5 that routinely circulate and don't cause much trouble compared to what we've seen now. But yeah, those are just a couple of the things off the top of my head. There are lots of other really important and great questions we should be asking. And maybe Asha, you've got some more.
Definitely. I do think that, say, the work that we've been doing in the task force has been providing guidelines for treatment of a very small number of children who really get to that pointy end of needing therapeutic options that might help them get through COVID better than they otherwise would. And I do think these children's lives have been saved by the evidence that's provided in it. That is a really, really small number in comparison to the vast majority of children whose lives have been quite disrupted now in their third year. A lot of missed school days, a lot of anxiety based on uncertainties, not knowing whether grandparents are going to get sick, whether they can go to school, whether they might have potentially passed on the virus from themselves to their mum or dad or their baby sister and things like that. So I think that a lot of our work as paediatricians is actually going to be in that big picture. What have been the impacts of a pandemic? What have been the impacts of the public health restrictions that have been introduced? How do we recover as a society together? And how do we, I guess, find the innovations, the ways forward, and the different ways of doing business as hospitals, as healthcare researchers, that we can really learn from this experience. So I do think that there's lots and lots and lots of research still to do. I'm probably, as an infectious diseases specialist, heavily weighted towards, thinking about what treatments might work best and that sort of thing. But I'm also, I guess, really paying attention to those in the community health paediatricians and psychiatrists who are starting to see more and more of the impacts of a pandemic from the non-infectious components of the pandemic. So I do think there's going to be a role for evidence in that zone, how to help young people navigate through difficult experiences, how to help young people move past anxieties and things like that, as well as, diagnostic tools and things. So I think there's a huge scope of things that we haven't even yet started to tap, but we probably will be looking for living evidence recommendations in the future.
Sounds like there's going to be a lot of work for you guys, both inside and outside the task force for the next little while. So I won't take up too much more of your time. I do feel like I've got another 17 questions, so we might get you back for another episode in the future. But today I'd just like to say thanks so much for your time. And to everybody listening and watching this show, I just want to say I hope you've enjoyed this conversation as much as I have. Please don't hesitate to send us your questions so we can ask experts like Asha and Brendan your questions too, and share this show with your clinical colleagues, and look out for our next episode. Thanks very much, everyone.